Hey there, future nurses and clinicians. Look, if you're gearing up for your boards, you definitely know the stress of trying to memorize every single little detail. But today, we're cutting straight through all that noise. In this focused ATI and NCLEX explainer, we are tackling a massive, high-stakes, frequent flyer topic, the respiratory system. We're totally stripping away the fluff and just pulling the absolute highest yield facts straight from the source material so you can walk into that exam room with total confidence. Okay, let's dive right in. Well, before we even look at a single lung today, I actually want to test your active recall with the absolute golden rule of nursing. When you're staring down a really tricky exam question, or honestly, when you walk into any patient's room, what is the very first priority in patient care? Think about your foundational frameworks here. You guessed it, airway. On the NCLEX, your ABCs, airway, breathing, circulation, they always come first. Securing the airway is literally the foundation of everything we do. Because if your patient can't breathe, nothing else matters, right? Keep that front and center in your mind as we move through this material. So, to make your learning incredibly efficient today, our explainer is broken down into 5 core pillars: essential E&P, focused assessment, diagnostics, interventions, and crucial pharmacology. Let's get to it. Section 1. Essential anatomy and physiology. Establishing our mechanical baseline. To truly understand these respiratory disease states, you absolutely have to master the baseline. Think about inspiration for a second. It is a highly active process. Your diaphragm contracts and pulls downward, which creates negative intrapulmonic pressure to literally suck air right into the lungs. But then, conversely, expiration is entirely passive. Those muscles just relax, the diaphragm moves back up, and that natural elastic recoil pushes the air right back out. So active inspiration, passive expiration. Highly, highly testable. Section 2, focused respiratory assessment, spotting those clinical abnormalities. Okay, so the boards heavily test your ability to immediately recognize clinical red flags. You need to know these distinct breath sounds. If you hear a wheeze, think of a high-pitched musical kind of sound caused by narrowed passageways, like you'd see in asthma. Rhonchi, on the other hand, is a low-pitched rattling sound from a partial obstruction, and it often clears up if the patient coughs. And crackles? Imagine the sound of rubbing a strand of hair between your fingers or like slowly opening up Velcro. That means there's fluid in the alveoli, think heart failure, and it does not clear with coughing. You've also got to assess for signs of chronic issues. For instance, a normal nail angle sits perfectly at 160 degrees, which creates this tiny little diamond-shaped space when you put your fingers together. But with advanced clubbing, that angle flattens out, it becomes greater than 180 degrees, and that little diamond space, it completely disappears. That is a massive visual red flag for chronic hypoxia. Moving right along to Section 3, need to know diagnostics, keeping our patients safe during testing. The NCLEX doesn't just test you on how to do a procedure, it aggressively tests patient safety beforehand. Enter the modified Allen test. This is an absolute must-know before anyone draws an arterial blood gas or ABG. Step 1, you firmly occlude both the radial and ulnar arteries while the patient makes a tight fist. Step 2, you have them open their hand, which should look pretty pale at this point. Step 3, release the pressure on the ulnar artery only. If their collateral circulation is good to go, a healthy pink color quickly returns. When you're doing this in clinical practice, confirming that safety is everything, you're looking for that pale, blanched hand to immediately flush with color the second you release that ulnar side, even while you're still holding down the radial artery. That's what a positive, safe Allen test looks like. But listen, if that color doesn't return, do not puncture that radial artery. Section 4, high-priority respiratory interventions, time for action. I know complex hardware like chest tubes can seem super intimidating, but let's just make it really simple. A disposable chest drainage system is inserted right into the pleural space to pull out air or fluid. And you absolutely must know its 3 main components. You've got the suction control chamber, which regulates the amount of suction being applied. Then there's the water seal chamber, which is crucial because it prevents air from flowing backwards into the patient. And finally, the drainage collection chamber, which is where you physically measure the fluid output. Now, distinguishing between a completely normal finding and a full-blown emergency here is absolutely critical for the boards. In that water seal chamber, you expect to see the fluid level rise and fall naturally with the patient's breathing. That's called tidling, and it's totally perfectly normal. But continuous bubbling in that water seal chamber, stop right there. That is a massive NCLEX red flag telling you there is a dangerous air leak. Another really high-stress intervention is tracheostomy suctioning. Remember, you only do this when it's clinically necessary, never on a strict, rigid schedule. When you do have to suction, these are your golden rules. You must use strict sterile technique. You absolutely have to pre-oxygenate that patient with 100% O2 before you even start. You only apply suction intermittently while you're rotating and withdrawing the catheter. And crucially, you strictly limit the actual suctioning to 10 to 15 seconds max per pass. Section 5. Crucial respiratory pharmacology, the essential meds you need to know. So the big takeaway here is truly understanding the difference between rescue meds and maintenance meds. On one hand, we have our bronchodilators, specifically short-acting beta-2 agonists like albuterol. These act directly to relax the smooth muscle in the bronchs. They are your fast-acting emergency rescue inhalers. Expected side effects? Think tachycardia, tremors, and restlessness. On the other hand, we have corticosteroids, like prednisone or inhaled budesonide. These do not relax muscle at all. Instead, they reduce the underlying inflammation over time. They're for long-term maintenance. And if they're given systemically, you really have to watch out for fluid retention and a much higher risk of infection. And of course, your nursing interventions tie directly back to those specific mechanisms and side effects. If a patient is taking multiple puffs of an inhaler, you've got to teach them to wait at least a full minute between puffs. That lets the first dose open the airways so the second dose can actually get in there. If they're using an inhaled corticosteroid, they absolutely must rinse their mouth out with water afterward. If they skip that, they are at a super high risk for developing a nasty oral yeast infection, basically thrush. And as always with bronchodilators, keep a close eye on their vital signs, especially monitoring for that elevated heart rate. Wow, okay, we've covered a tremendous amount of ground today. So let's wrap this up by challenging you with a real NCLEX-style clinical judgment question. We just talked about that strict 10 to 15 second rule for tracheostomy suctioning, right? But why? Why is it so incredibly vital to limit that suction time? Think practically about what you're physically doing to the patient in that moment. Because suctioning literally removes the oxygen, which can cause severe hypoxemia. When you slide that catheter down their airway, you aren't just pulling up mucus and secretions. You are actively vacuuming out the vital oxygen your patient needs to survive. Patient safety and maintaining that airway, those are always the ultimate goals of nursing care. So ask yourself, if a patient's life depended on it right this second, would you remember the difference between rhonchi and crackles? Keep your frameworks fresh, trust the knowledge you've built, and I will see you in the next explainer.